So, many years ago, we learned that lumpectomy and mastectomy give the exact same survival. 25 years later, survival's the same whether a woman had a lumpectomy or mastectomy. But over time, we've learned what it takes to do a safe lumpectomy. And that means getting what we call microscopically clean margins, so that when the pathologist tests the edges of what's been removed, there's no cancer at the edges. And the problem is we care about even microscopic amounts of disease that's too small to see or feel, and even too small to show up on a standard X-ray or mammogram. So when we do a lumpectomy, about 20% of the time now, the final margins end up not being clean. And because with current technology, the pathologist can't give us that information on the spot, it takes a week or so to learn that the margins are not clean enough. And then the patient has to have a second surgery to go back, get extra tissue from that area. And that's stressful. There's more discomfort. It's all the expenses of a second surgery, and potentially also a delay in getting to the other treatments that you would need. The Luma system is designed to try to get around several of these problems with standard of care. The first is that it gives you the information immediately. So after the surgeon does the standard lumpectomy, we would then look inside the cavity with the Luma system to see if there's any tumor left. And we're looking right in the patient at the area where the tumor might be left behind. And we're looking with just light, so it doesn't cause any trauma to the tissue or anything like that, and that's great. The other thing is it's actually a much more thorough look at the cavity where the tumor used to be than pathologists can do, because they have to take the tissue and make thin slices and put it on little glass slides to look at, and they can only really closely examine about 1% of that tissue surface, whereas this device can look at the entire cavity in about a minute. And so what we found as we were using this is that this allowed us to remove tumor that would otherwise have been left behind by our standard surgery and that might not have even been recognized. And it spared certain patients a second operation. So that's the goal of this system, to see the tumor, see it right away, and let the surgeon do the extra trimming that needs to be done on the spot. So it's been used now in more than 800 patients. It's given it works by giving an intravenous dye right before surgery. The dye becomes fluorescent in regions of residual tumor that shows us what to take out. And as with any medicine, there are some people who can have some allergic reactions to. Our allergic reaction rate in these studies was about 0.6%. And that's similar to the rate of allergic reactions we see with other dyes that we use in medical imaging. It does a couple of things. First, the idea of being able to remove more tumor and save second surgeries is a great thing. It's also organized and set up in a way that's more rational than what we're doing now. It's looking at the cavity where the tumor is instead of trying to study the surface of a piece of tissue that's been removed and has changed shape. And I think this being the very first product that can do this, that takes this approach and has this ability, is also going to open things up for advances in all other types of tumors. The system can be potentially used for other body parts. And it's going to set an example that I think can spur a lot of innovation in the near future.